Good morning, everyone. Today we will be seeing about developmental disturbances of teeth. Developmental disturbance of teeth, they can be classified into developmental anomalies which occur during the disturbance due to disturbance during formation of teeth, or acquired anomalies of teeth which is initiated after the development of teeth or due to changes in normal function and faulty habits. As I said, the developmental disturbance can be due to developmental anomalies or due to acquired anomalies. In developmental anomalies, they can be seen as abnormality in number, size, shape or morphology, eruption or structure. Acquired anomalies include attrition, abrasion, erosion, internal resorption, external resorption, pulp stones, pulpal sclerosis, hypercementosis. So first, we will be seeing the developmental anomalies, the abnormalities in number of teeth. Primarily, supernumerary teeth. These include mesiodonts, parodontia, distodonts, and hypodontia. Supernumerary teeth, as the name suggests, they are supplemental teeth or extra tooth that has the same normal morphology. Mesiodonts is usually seen between central incisors. Paramolars are teeth which occur in the molar region. Distodonts or distomolars, as the name suggests, they occur distal to the third molars. Periodonts are teeth which occur buccally or lingually. Supernumerary teeth is seen in 4% of the population. In the maxillary arch, the anterior region and the molar region are the two places where supernumerary teeth are more commonly seen. In the mandible, premolar region. A predominance is being seen in males, and these supernumerary teeth are usually seen outside the arch. The supernumerary teeth, they usually have conical shape. They are smaller in size when compared to normal teeth. Certain times they can interfere with normal eruption. Differential diagnosis, you need to differentiate it from cleidocranial dysostosis or Gardner's syndrome. The most preferable treatment is extraction of the supernumerary teeth. Again, the abnormality in number, they can be missing teeth. Anodontia signifies absence of all teeth. Hypodontia, absence of one or more teeth. Oligodontia, numerous teeth. Oligodontia or hypodontia or partial anodontia. Anodontia can be totally edentulous. So anodontia can be true anodontia or pseudo anodontia. True anodontia is when the teeth are congenitally missing. Pseudo anodontia is due to after extractions. Anodontia is more commonly seen or mostly seen in the third molar region in relation to premolars, maxillary lateral incisors, mandibular central incisors. They are usually associated with ectodermal dysplasias. The next abnormality in number is the ectodermal dysplasia. Ectodermal dysplasia is an X-linked disorder. It is inherited, where you can see partial or complete absence of teeth. A more predominance is seen in males. They will also have saddle nose, scanty hair, scanty eyebrows. Due to the absence of the teeth, the alveolar process will not develop much, and the palate, you can see that it will be a high arched palate. In ectodermal dysplasia, there also will be supraorbital and frontal bossing. The skin of these patients, they'll be very dry and scaly. This is due to the absence of sweat glands. Radiographically, we can get the OPG or the radiographs, which will help in confirming the missing teeth. The most favorable treatment is prosthetic rehabilitation. The next developmental abnormality is abnormality in size. It can either be macrodontia. Macrodontia is when the teeth is larger than the normal size. This can be seen in a single tooth or a group of teeth. It is usually associated with pituitary gigantism, hemifacial hypertrophy. Hemangioma can also cause an increase in size. Clinically, you will see that the teeth are larger, so it can cause crowding, malocclusion, and certain teeth can also be impacted. You need to differentiate it from fusion and gemination. Orthodontic correction, as and when required, can be done, or veneering of the teeth. Next abnormality in size is microdontia. As the name suggests, the teeth will be smaller in size. This is usually seen with pituitary gigantism. Here, the smaller, as you can see, the size of the tooth will be smaller. So, in molars, you will see reduced cusps. In lateral incisors, you will see peg-shaped laterals. Differential diagnosis in congenital heart disease and progeria. You can use restorative treatment to correct it or veneering or other aesthetic treatments. Moving on, we will see the abnormalities in shape. Abnormalities in shape include fusion, gemination, dens indentate, dens invaginatus, talus cusp, taurodontism, concrescence, dilaceration affecting the roots, and supernumerary roots. So firstly, we'll see fusion. Fusion is also known as synodontia, where the adjacent tooth germ combine before calcification. So you will see they are fused teeth. It most commonly affects mandibular region. Both genders are equally affected. More seen in deciduous dentition. In the deciduous dentition, canines and the lateral incisors are more commonly fused. In primary dentition, the central incisor and the lateral incisors are more commonly affected. Radiographically, you will see that there is a fused tooth. The configuration of the pulp chamber, you will see there is an unusual configuration of the pulp chamber and the root canal. We need to differentiate it from gemination and macrodontia. For treatment, in permanent dentition, you can give 2 independent crowns. Next is gemination. Gemination is also known as twinning. Gemination can be complete or incomplete. It is more commonly seen in deciduous teeth, especially in the incisor region. Both genders are equally affected. Radiographically, you will see altered hard tissue and pulp chamber. The radiopaque enamel, you will see that it outlines the clefts in the crown. The pulp chamber will appear enlarged. We need to differentiate it from fusion. Next abnormality in shape is concrescence. This affects the root when 2 or more teeth are united in the cementum region. The most common cause is localized trauma. It can also occur due to excessive occlusal forces or due to a local infection. They have 2 types, true and acquired. True is which occurs during development. Acquired is which occurs after development. Concrescence can involve both the primary and the permanent dentition. Maxillary molars, that is especially the third molars, are seen more affected by it. Radiographically, you will see there is an extent of fusion in the root region. Next is dense in dentate. Dense in dentate is also named as dens invaginatus or a dilated odontome. This occurs because of an infolding of the outer surface into the tooth. It can affect both the crown and the root. Most extreme form is the dilated odontome. It primarily affects the maxillary anterior teeth, especially the lateral incisor, then the central incisor, followed by the premolars and the canines. Posterior teeth are rarely affected. It is seen as an enamel-lined pit from the cingulum, and this region is very prone to caries. Radiographically, it can easily be identified because there will be an infolding of the enamel lining and it appears as a radio-opaque region. Treatment, you can do root canal treatments or restoration in case the area is affected by caries. Dense invaginatus, also known as Leong's premolars, occlusal enamel pearl. This usually affects about 2% of the Chinese, Japanese, or American Indian population. Here you will see that there is the pulp extending into the occlusal tubercle, and this needs to be considered especially during restorations. Radiographically, you will see that the dentine core is covered with enamel with an extension of the tubercle on the occlusal surface. As I said before, during restoration, if you see that there is an occlusal interference, pulp capping must be done. Enamel pearls. A tiny globule of enamel is seen at the bifurcation or trifurcation of the molar root. It is formed by the Hertwig's epithelial root sheath. It can be seen in 2% of maxillary molars, but less than 0.5% of mandibular molars are affected by enamel pearls. Radiographically, it is seen as a smooth, round, and comparable radiopacity to that of enamel. It is seen in the furcation areas and can cause a periodontal pocket. So we need to differentiate it from calculus in that area or pulp stones. And it needs to be removed before causing further periodontal problems. Next is the Talon's cusp. It affects the incisors in either jaw, in the maxillary as well as in the mandibular jaw. It is composed of normal enamel and dentine, which blends with the sloping lingual surface of the crown. It can affect both the genders. It is seen as an incisal edge as a T-shaped appearance. Pulpal extension sometimes may not be there. Radiographically, the cusp is seen. The outline can be traced. Pulp horns may or may not be seen. If it is very large, it can cause malocclusion and it can appear anesthetic. When it appears anesthetically, endodontic treatment can be considered. Moving on, now we will see the developmental anomalies in relation to teeth, especially in the root morphology, affecting the root morphology. Firstly, dilacerations. This is an angulation or a sharp dent in the root or crown that is formed in the tooth. It occurs due to trauma. It is difficult to see radiographically if the bending is buccolingual. Usually, it affects permanent molars. You need to differentiate it from fused root and dense bone eyelid. Next is toroodontism. Posterior teeth with long pulp chambers and short roots or bull-like teeth. They can affect. Toroodontism can be seen in both primary and permanent dentition. It is usually associated with Klinefelter syndrome. Radiographically, the crowns will appear normal, but the root and the root canals appear shortened. Pulp chambers, you will see that they appear as a rectangular appearance. Next is abnormality in eruption. Premature eruption. Neonate teeth, that is the teeth which erupt within 30 days. Natal teeth, that is present at birth. Natal teeth is usually associated with Ragavan disease. So the treatment of choice can be extraction or sometimes rounding the sharp edges. Next is transposition. This is a condition where two teeth exchange position. This is more commonly seen in permanent canines and the first premolars. Sometimes it can be seen between the second premolar. The second premolar can be seen between the first molar and the second molar. Radiographically, the position sequence can be seen as transposition. So treatment of option is orthodontic correction. Next abnormality in eruption is embedded, impacted or submerged teeth. Embedded teeth is basically because of the lack of eruption forces. Impacted teeth can be due to the physical barrier. Submerged teeth, that is the teeth that is below the line of occlusion. Most commonly, the third molar is affected, both in the maxillary and the mandibular region, followed by maxillary cuspid. Treatment of choice is whenever required extraction. Next is the developmental anomalies of teeth affecting the structure of teeth. Firstly is amelogenesis imperfecta. This interferes in the enamel formation. All teeth in primary and permanent dentition can be affected by this. There are four main types: hypoplastic, hypomaturation, hypocalcified, hypomaturation and hypocalcified type. Radiographically, you will see that the radio-opaque layer of enamel is thinned. Pitted enamel can also be seen. In hypomaturation type, the normal thickness of enamel is comparable to that of dentine. In hypocalcified type, the normal enamel thickness is less than that of dentine. In advanced abrasion cases, obliteration of the pulp will also be seen. We need to differentiate it from dentinogenesis imperfecta. Treatment of choice is a crown placement or veneering whenever possible. Next abnormality in structure is dentinogenesis imperfecta. This occurs due to developmental disturbance of dentine along with thinning of enamel. They are of two main types. The first type is associated with osteogenesis imperfecta. This affects the tooth roots and the pulp chamber. That is, they'll be underdeveloped. Type 1 affects the primary dentition. Type 2, only the dentine is affected. In the primary dentition, when it is affected, in type 2, you will see that the pulp chambers are enlarged. Clinically, you will see that the enamel fractures easily, anterior open bite will be there, and exposed stained dentine will be seen. Radiographically, there will be marked attrition in the occlusal surface. Roots will be short and slender. In developmental stage, large pulp chambers will be seen. Periapical radiolucencies will be there surrounding the normal bone. Next abnormality in structure is regional odontodysplasia, also known as odontogenesis imperfecta. This affects the teeth in one quadrant or one segment. These teeth are also called as ghost teeth. This occurs due to failure and eruption of the affected teeth. You can see that there will be a dilated follicular space with calcifications. Clinically, the teeth will be small or mottled brown. Central incisors, lateral incisors, and canines are most commonly affected. Radiographically, the ghost teeth will be more evident. That is, the pulp chambers are large, root canals will be wide, enamel will be thin and poorly mineralized. We need to differentiate this from dentinogenesis imperfecta. Dentine dysplasia is the next abnormality in structure. Type 1, you will see that they are radicular, that is normal in color. A bluish brown translucency is there in teeth. The teeth will be malaligned. The roots will be short or abnormally shaped. Type 2 is the coronal type. There will be obliteration of the pulp chamber. The pulp will become flame shaped and multiple pulp stones will be there. The next abnormality in structure is Turner's hypoplasia, also known as Turner's tooth. Permanent tooth, local hypoplastic defect is seen in the crown. This is caused due to the extension of periapical infection from primary teeth or due to some mechanical trauma. Most commonly, they affect the mandibular premolar region, where you will see hypomineralized area, stained or brownish spots. In the crown, you will see that there is pronounced defect. Radiographically, an ill-defined radiolucent areas. So we need to differentiate it from caries, especially after radiation therapy. Next is the acquired anomalies of teeth. So till now we were seeing the developmental anomalies of teeth, various size, affecting the size, shape, structure. Next is the acquired anomalies of teeth. First is attrition. Attrition is a regressive change. Clinically, you will see that the incisal and the occlusal surfaces are abraded. It can be due to bruxism also. The dentine becomes thin and it is exposed. There will be flattening of cusps and pronounced facets. Radiographically, the crown will be shortened. Reduction in size of the pulp chamber and root canal will be seen. Alveolar bone loss will be seen. Widening of periodontal ligament space with mobility is seen in certain cases. Next acquired abnormality is abrasion. It is a non-physiological wearing contact with foreign substance. Clinically, it can be seen causing a V-shaped groove and the teeth will be sensitive. The most commonly affected teeth are premolars. Radiographically, there will be a radiolucent region in the cervical area or a band-like radiolucency at the cervical region. Next is the erosion. Erosion is caused by chemical action, acid or due to the acid from chronic vomiting or acid reflux or taking too much of citric fruits. Clinically, the incisors are more prone to this. Lesions, you will see that they are smooth, glistened depressions on enamel near the gingival region. Radiographically, radiolucent defects on the crown, or they'll be well-defined or diffused regions. Next is the internal resorption. This occurs within the pulp chamber or within the pulp canal. It involves resorption of the surrounding dentine. There will be enlargement of the pulp space. This is usually initiated by acute trauma, sometimes by direct or indirect pulp gapping. It mainly affects permanent teeth, especially the central incisors, first and the second molars. A pink spot is very commonly seen in such teeth. Radiographically, you will see that there is radiolucency. It can be round or oval with elongated within the roots. It will be continuous with the pulp chamber. You need to differentiate it from external resorption or other cystic lesions. External resorption. The odontoclasts resorb in the outer surface involving the root surface. The main causes of external resorption can be localized inflammation, reimplanted teeth, excessive mechanical, and due to excessive occlusal forces. Radiographically, you will see that there is a blunting of the root apex, bone, and the lamina dura. The pulp canal will be wide. There can be lateral resorption, which will be seen involving one side. Hypercementosis. This is excessive deposition of cementum on the root area. It can be caused due to reaction to inflammatory process, hyperocclusion, or even due to fractures. It is seen associated with Paget's disease and acromegaly. Radiographically, we will see that there is an excessive buildup of cementum around the root. The outline is smooth but bulbous. Cementum appears more radiolucent. The lamina dura and the periodontal ligament space surrounding, you will see that there is extra cementum. So we need to differentiate it from periapical cemental dysplasia and a fused root. With this, we come to an end of the developmental anomalies of teeth. So we need to remember that developmental anomalies, they can either be developmental, that is before birth, or acquired, which is after the development of teeth. Developmental anomalies can affect the site, shape, structure of the teeth, whereas acquired anomalies include attrition, abrasion, erosion, internal resorption, external resorption, etc. Permanent dentition is more commonly affected in all these cases. I hope you've enjoyed the session. Thank you.